The rationale behind FFR Surge is we are looking towards ways of improving stent outcome. We know that when we implant stents we have relatively or fairly good outcome, but there still is room to improvement, especially if you compare in multivessel disease and compared to surgery. So we are looking into the new ways of doing that, but also these ways need to be reproducible, but they also need to be easy to apply. So the study design followed my first introduction to a microcatheter-based FFR measurement tool, which is the novice ACIST system. It's a microcatheter, so it allows you to use a genuine guide wire, coronary guide wire, to do an FFR assessment. The result is that you don't have to wire with an FFR dedicated wire. You don't have to rewire a lesion. And that opens up a lot of opportunities. The major opportunity is that once you've put in a stent and your wire is still in the distal vessel, you can use that wire to advance the microcatheter, do your FFR, and then do a pullback to see whether and if there is, where is a drop of pressure. In terms of study design, we designed an all-comer kind of study. It's called FFR Surge. It's an analogy to the E-Surge, Research, T-Surge studies that we did previously in Rotterdam. And the idea is in all the patients where we put in a stent, we would evaluate the final result by FFR. So when the operator was satisfied angiographically with the result, then we would do the FFR, but we were not supposed to act upon the FFR. So we want to use these FFR results and see whether they will predict outcome in the long run. So Roberto Diletti presented at this year's PCR the 30-day outcome. So this is a preliminary analysis because the primary endpoint is at 2 years. So major adverse events at 2 years. But what we presented today was, first of all, what is the FFR post-stenting? Is it different in different sets of patients? Because we were doing these FFR assessments in patients with STEMI, non-STEMI and stable patients. And were there values that were lower than expected? And it turned out that in 20% of the patients, the FFR was below 0.85. In 43% of the patients, the FFR was below 0.90. So these were quite surprising results. So the question is, what does that mean? And you know, at a 30-day endpoint, there is not much to say in terms of outcome. We are definitely waiting for our 2 years results to have a good say on whether or not it makes a lot of sense to do an FFR assessment after stenting. What we do know is that in the patients where we see a low FFR, we did in a subgroup analysis, we did additional imaging to see what was the reason for this suboptimal FFR. And then we had some mechanisms like stent underdeployment and focal lesions and also diffuse disease. And it's interesting that in 60% of the patients there was focal disease in combination with some kind of a stent underdeployment. The practical experience is very favorable, so it's very easy to use, it's intuitive, and it is applicable in the majority of cases. We specifically did not use it in patients who were in cardiogenic shock or in very cumbersome procedures, because we don't want to expose those kind of patients to adenosine, because we were not doing IFR, we were doing FFR. What we did was in the patients where the FFR was lower than expected, so below 0.85, we used new technologies called HD IVUS, high definition IVUS, which is a 60 megahertz device. It's called a Kodama catheter. It's an IVUS system that allows you for a very fast pullback and has a very high spatial resolution. We use that device to evaluate vessels with an FFR below 0.85, and again it showed us that there was a significant number of patients, some residual focal disease, but also stent underexpansion.